put his head down flat, I would have to put this tube feeding on hold. Notice how it's flashing? I would put it on hold instead of turning the power off, because this is my slave, and this will alarm in 4 minutes, and it will remind me, Jen, you turn that off. Do you want to continue keeping it off? And I'll say, oh, actually, yeah. All right, I do want another 4 minutes. I'm not done changing his bed or doing his pericare, rubbing his back, whatever I want to be doing. But if you just turn it off, this is when you could leave the room and come back later and find out he's missed an hour of his calories or 2 hours or 3 hours or however long it takes to get back to that room. So I recommend putting it on hold so you can put them down in a low position. All right. You're laughing. Why are you laughing? What did I do?
Nothing. Probably just looks funny.
All right. Okay. So that's the case with continuous feeding. All right, that I would come and I would stop it and I would check for residual and so on and so forth. But we would like to talk about the case of the intermittent feeding that you're going to do on your practicum. So this is the same process of the chart and the order and the assessment and this and the same NANDA and so on. And what's different about it is the actual administration of the feeding. So in this, you can either aspirate the tube feeding and push it in slowly, all right, to the volume that the doctor wanted, or you could, and you need to keep this clean. It's not like you could be leaving it laying around. You actually put it in the package because that's sterile. You could do this and go ahead and pour in your tube feeding. And, oh cool, there's some water. And one of the things is you can't put it really high up because it's just a gravity feed and you're in a hurry and you want it to go down really fast, because the higher you lift it, right, it goes in with greater pressure. All right, so you can only lift it about 12 to 18 inches above their head. All right, you could let it go down. And usually I don't let it do this because now there's a bunch of air in the tubing. So as it came down to the bottom, I would have crimped it and put the rest in. Do you see what I mean? And as the fluid is coming down, I'm kind of crimping the tubing. All right, and then last I would need to put in water. All right, so I put an ounce of water in because you're always flushing the tube. And in actual fact, one of the problems with tube-fed people is they get the tube feedings tend to be very hypertonic, and so it's pulling water towards it, and so they're getting what's called hyperosmolar dehydration. They actually get cellular dehydration if you're not actually giving them free water. So one thing we might get asked to do is give them the tube feeding every so many hours, but to give them 8 ounces of free water, as they say. So we might just be asked to come and give them water. All right, to give them adequate hydration. All right, and then my aftercare of the tube feeding would be what? I've administered my tube feeding.
You want to check that?
I'm going to document. But could I just put his head down and okay, I want to turn you over and just No, he needs to remain seating for 30 minutes, so I would tell him that. I would make sure that the family and the nurse's aide and everyone else knows they wouldn't lay him down and increase his risk of aspiration. And then, yes, it's true, I'd go out to the chart and now I'd want to document. So I'm going to document, altered nutrition, less than body requirements, related to dysphagia. And my actions are, please make your charting indicate somewhere. And they frequently do this as a check charting thing and talk about a more, in some ways, serious problem. But I want to say that I checked the placement. I verified the placement of the tube. If that patient aspirates later today, I want it shown on that chart that when I put that stuff down there, it was good to go. All right? So I'm going to say verified tube placement. And I usually say how I did it, using, with pH, insufflation, aspiration of cell contacts, whatever my technique is, all right. My residual was 10 or 15 cc's, but frequently they have this on a check chart. Check placement, check residual, and you actually put the volume in there. All right, and I'd say replace that. Then I would say I administer the tube feeding per physician's order. You could actually say what it was, Pulmicare 30 cc's or whatever it is, and so on. And then what is my desired response? Oh, pardon me, I'd also want to have the abdominal assessment. Patient has active bowel sounds. And usually the normal finding is a flat, non-tender abdomen, right? And bowel sounds are present in all 4 quadrants. And
patient tolerated it well.
Yeah, how they're doing with it, all right. And that the head of the bed was left up is another key thing, and so on. And then, but I want to talk about, this is a problem with nutrition, so I could say, their weight, their labs, their all that other stuff. All right? Okay.
What do you say about their weight if you just, like, do you just check
I could
for
say
it and
patient's weight is the same as last week, or patient's weight is decreased by a kilogram or whatever. So we're going to talk a little bit more about that, understanding all of that next week. All right. One thing I want you to see is, Namiko brought this up, is this what she uses at her facility. This was the screen to know about whether or not a patient needed to be considered for a swallowing study. So do you see how this works?